Hello, my name is Melinda Cory, and in this video we are going to review transposition physiology and discuss the importance of effective blood flow. I have no financial disclosures or conflicts of interest that are relevant to the information included in this learning resource. In this talk, we are going to answer the following questions. What is effective blood flow? Is there a difference between the anatomic shunt and the physiologic shunt? What is the most important area for mixing in the heart? Why do we start prostaglandins? Before we can answer these questions, we first have to discuss the problem. In transposition physiology, there are two parallel circulations. There is oxygenated blood that is continually circulating through the pulmonary bed, and deoxygenated blood that is continuously circulating through the body. The oxygenated blood that isn't making it to the body and the deoxygenated blood isn't making it to the lungs. It is this lack of mixing that creates the primary problem in transposition physiology. So in order to understand the mixing that must occur, we have to talk about effective blood flow. Effective pulmonary blood flow, or QP effective, is the amount of deoxygenated blood that actually makes it to the pulmonary bed for oxygenation. Effective systemic blood flow, or QS effective, is the oxygenated blood that makes it to the systemic circulation for oxygen delivery. Essentially, the effective blood flow, or Q effective, is the volume of mixing, and this is the most important amount of blood volume that patients with transposition physiology have. In order to calculate the effective blood flow, we can use the modified Fick equation. For effective blood flow, we have to choose the most oxygenated blood, and we subtract out the least oxygenated blood. So we use our pulmonary vein saturation as the most oxygenated blood, and we use our systemic vein saturation as our least oxygenated blood. Using these values, we can calculate the volume of mixing within transposition physiology. Let's walk through this diagram to understand this further. I have set up a diagram with the two parallel circulations to represent a patient with transposition physiology. Let's start with the deoxygenated blood. All of the blood returning from the body back to the heart is our QS, or systemic blood flow. Once this blood returns through the systemic veins to the right atrium, the majority of the blood continues to the right ventricle and back to the aorta due to the abnormal ventriculo-arterial connections in patients with detransposition. All of the blood that continues from the right atrium to the right ventricle to the aorta is a physiologic right-to-left shunt because it completely bypasses the lungs and goes straight back to the body without undergoing oxygenation. But some of this blood crosses over to the pulmonary circulation through an anatomic shunt. It is this blood volume that is the effective pulmonary blood flow. Now let's move to the oxygenated blood. All of the blood returning from the lungs back to the heart is the QP, or pulmonary blood flow. All of this blood returns to the pulmonary veins back to the left atrium. The majority of this blood continues through the left atrium to the left ventricle and back to the pulmonary artery for continued oxygenation. This blood volume is the physiologic left-to-right shunt because it is bypassing oxygen delivery and going straight back to the pulmonary bed. A small amount of blood is able to cross over from the left side of the heart to the right side of the heart and ultimately out to the aorta. The amount of blood that is crossing from the left side of the heart to the right side of the heart becomes our QS effective because it is what allows the oxygenated blood to go to the aorta and ultimately out to the body for oxygen delivery. And so it is these points of mixing between the parallel circulations that allow for oxygenated blood to make it to the body and deoxygenated blood to make it back to the lungs. Taking this back to the Fick equation, let's walk through a couple of patient examples to show how the volume of mixing affects patient saturations. Here we have a diagram of a heart with saturations that were measured in different areas. This is a patient example with a systemic oxygen saturation of 88%. To calculate the Q effective blood flow, we want to take the most and least oxygenated blood for our calculation. We can take the pulmonary vein saturation for the most oxygenated and the SVC saturation for the least oxygenated. We are given the hemoglobin of 15 and VO2 of 200. Plug these numbers into our equation and we get 3.2 liters per minute for the Q effective blood flow, which tells us the volume of mixing. Now, here is a patient example with systemic saturations of 70%, with the hemoglobin and VO2 the same as the prior example. Let's take the highest saturation from the pulmonary veins and the lowest saturation from the SVC and plug them into our equation. We get 2 liters per minute for the Q effective blood flow. So comparing the two examples, you can see that the volume of mixing is higher for the patient with the higher systemic saturations than in the patient with the lower systemic saturations. We don't often calculate the Q effective in the clinical realm, but knowing this principle can help us understand why a patient with transposition physiology is desaturated. So now that we understand why effective blood flow and mixing are important in these patients, we need to think about the possible areas for mixing and which areas are the most important. Our options are the patent ductus arteriosus, the atrial septal defect, and the ventricular septal defect. We'll walk through each of these to discuss the physiology behind each area of mixing, and then we will be able to determine which is the most effective area for mixing. Let's start with the PDA. In general, the aortic blood pressure is higher than the pulmonary artery blood pressure. Because of this, the majority of the blood shunts from the aorta to the pulmonary artery. This allows deoxygenated blood from the aorta to shunt to the pulmonary bed, allowing for oxygenation. There is very little blood flow that moves from the pulmonary artery to the aorta. If the pulmonary artery pressure is high, you can get shunting from the PA to the aorta, but in general, the majority of blood is shunting from the aorta to the pulmonary artery. So this improves our ability to get deoxygenated blood to the lungs, but this does not improve our ability to get oxygenated blood to the body. The next area of mixing that we will discuss is the ventricular septal defect. The right ventricle is the subaortic ventricle in transposition physiology. And because the aortic blood pressure is generally higher than the pulmonary artery blood pressure, the right ventricle blood pressure is higher than the left ventricle blood pressure. So the majority of blood is moving from the right ventricle to the left ventricle. And with transposition, the right ventricle has deoxygenated blood that is then being shunted across to the left ventricle. There is some degree of bidirectionality of the shunt depending on the size of the VSD, but again, by and large, the majority of the blood is deoxygenated blood moving to the pulmonary circulation, which does improve oxygenation but does not improve systemic oxygen delivery. The last area of mixing is the atrial septal defect. In general, the left and right atrial pressures are very similar. If the atrial septal defect is large, this allows for complete mixing in both directions. Deoxygenated blood moves to the pulmonary circulation, and oxygenated blood moves to the systemic circulation. This improves both oxygenation and systemic oxygen delivery. So what is the most important area for mixing? It's the atrial septal defect. That is the most important area for mixing for any patient with transposition physiology. So that begs the question. Why do we start prostaglandins if the PDA is not that important for mixing? Well, the shunting that we get across the PDA improves our mixing secondarily. A patient that does not have a PDA but only has an atrial septal defect, in general, has a reasonable amount of mixing across the atrial septal defect. However, if we keep the PDA open and allow shunting from the aorta to the pulmonary artery, then we've increased the pulmonary blood flow. And this blood ultimately comes back to the left atrium. With the increased amount of blood volume coming back to the left atrium, the LA pressure is increased, which ultimately increases the shunting from the left atrium to the right atrium across the atrial septal defect, resulting in more oxygenated blood moving to the systemic circulation, ultimately improving our systemic oxygen delivery. So the PDA can be quite helpful in improving oxygenation through increasing QP and then ultimately increasing mixing across the atrial septal defect. Based on this physiology, it is important to remember that a PDA without an ASD is not helpful. So that brings us to a restrictive atrial septum. In patients with detransposition, a restrictive atrial septum can be very deadly. So let's walk through what the symptoms of a restrictive atrial septum are. First, they're going to be hypoxemic. There is just not enough oxygenated blood making it to the systemic circulation. They also have signs of left atrial hypertension, and this is generally displayed by pulmonary congestion because there is a back pressure against the pulmonary veins, leading to increased pulmonary edema. And lastly, they can have low cardiac output. If a patient has these signs, we must assume that they have a restrictive atrial septum, and the only treatment for restrictive atrial septum is an emergent balloon atrial septostomy to open the atrial septum. Medical management strategies are primarily focused on either improving systemic oxygen delivery or reducing metabolic demand. In addition to starting prostaglandins, supplemental oxygen is often used. Other strategies to increase systemic oxygen delivery may include blood transfusion to increase the oxygen carrying capacity, or using inhaled nitric oxide to reduce the pulmonary vascular resistance and increase pulmonary blood flow. If increasing systemic oxygen delivery is not adequate, then strategies to decrease metabolic demand are important. This includes sedation, mechanical ventilation, neuromuscular blockade, and preventing fever. Ultimately, the definitive management for these patients is surgical repair. In general, the surgeons perform an arterial switch operation within the first 7 days of life. So to summarize, with transposition physiology, there's a parallel circulation. These patients depend on mixing lesions for effective pulmonary and systemic blood flow. The atrial septum is the most important area for mixing. PDA blood flow will increase blood return to the LA, ultimately resulting in increased oxygenated blood shunting to the systemic circulation. A restrictive atrial septum results in hypoxemia and low cardiac output and can be deadly in these patients. An emergent balloon atrial septostomy is required for restrictive atrial septum. And then ultimately, an arterial switch operation, usually within the first week of life, is the definitive management for these patients. So that brings us to the end of our talk about transposition physiology. Thank you.